Alhamdulillah. Okay, kita boleh start lah. Okay, sekian.
Okay. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. I bid to all my fellow friends and also our supervisor for this seminar, Dr. Alwi. So for this seminar, we'll be discussing 3 topics, which are growth disorders, short stature and tall stature, inborn errors of metabolism, and lastly, sepsis and septic shock. Okay. So the first topic will be growth disorders, to be presented by me. So this is the outline of my presentation, which include growth phases, average height velocity, measurement of height in children, growth hormone physiology, and also we'll be discussing some of the diseases under short stature and also tall stature. Okay. So for growth phases, there are 4 growth phases, which are first fetal, which is the fastest, that contributes about more than 30% of eventual height. Dr. Alwi, your mic is on.
What was it?
Okay, so next phase is the infantile phase, which is rapid, but also have a decelerating growth rate of 15%. And in childhood phase, which is a slow and steady phase, which contribute about 40% of the final height. And the pubertal phase, which is influenced by sex hormone, and contributed about 50% of final height. Okay. So next is about the average height velocity. So basically means that at which rate that a person is growing, and also it have a different rate at different phases. You can see in prenatal growth, it has a rate about 1.2 to 1.5 centimeter per week, and infancy about 23 to 28 centimeter per year, in childhood 5 to 6.5 centimeter per year, and lastly in puberty, there is a difference between girls and boys, in which in girls about 8.3 centimeter per year, and also in boys 9.5 centimeter per year. And what next is about the mid-parental height. So what is mid-parental height? So it is a child's projected adult height, which is calculated based on the height of the parent. So we can roughly estimate that what's the child height going to be in the adult by calculating the mid-parental height. We shall have a different formula for boys and girls. And next about the height measurement, which is measuring in height of children is different according to age. And for children of less than 2 years old, it's measured the length by lying down with the children held still, and it is the device is called an infantometer. And for the children of more than 2 years old, measure the height by standing up, and it's called a stadiometer. I forgot to put the name there. The reason I cannot, I try to search what's the rationale between why is the cut point is less than the 2 years old, less than 2 years old by lying down and more than 2 years old by standing up. But however, I cannot find the reason why. Okay. Okay. The doctor can clarify after this. Okay. And also a little bit revision on the growth hormone physiology. And as we know that the growth hormone is secreted by the anterior pituitary, and it has several effects on the skeletal, extraskeletal, and also fat metabolism, also carbohydrate metabolism. And you can see that the important chemicals such as insulin-like growth factors that have some role to play in some of the diseases that I will be explaining later. And it have an effect of negative feedback effect. It will in which it will inhibit the secretion of growth hormone by inhibiting the growth hormone releasing hormone release, and also stimulate growth hormone inhibiting hormone release that will inhibit the growth hormone synthesis and also release. And these are the effects of the growth hormone at each system. So this is an overview, and also can help in understanding some of the pathophysiology of the diseases that will be explained later. Okay. So next, we go into the what is short stature. So according to the pediatric protocol of addition, it has several definitions. So first, there is the height below the 10th percentile, or is a -2 standard deviation for age and gender. I will show the graph, the height chart later. And the height significantly below genetic potential is -2 standard deviation below mid-parental target. But however, I don't have the chart for this mid-parental target growth, and abnormally slow growth velocity, and maybe less than what the child should have at different phases. And lastly, downwardly crossing percentile channel on growth chart for more than 18 months age. So this is the length for age chart for boys. So we can see that the 0 is the what the normal one should be, and the -2 is -2 SD, also known as third percentile. Okay. So this is what meant by third percentile or -2 standard deviation. So this is for boys, and these are for the girls length for age chart. So it has different chart according to age. So I just put one here for from birth to 2 years old for boys and girls. So you can search other chart for other ages at the WHO website. Next, when we're talking about short stature, it has an array of etiologies, and it can be classified under variation of normal, which is constitutional and genetic, and can be caused by endocrinopathies, either by hypothyroidism, hypopituitarism, growth hormone deficiency, also Cushing syndrome. And so genetic disorders can also cause short stature, which is Down syndrome, Turner syndrome, Prader-Willi syndrome, and also Noonan syndrome. So skeletal dysplasia, achondroplasia, hypochondroplasia, and lastly, systemic chronic diseases such as inflammatory bowel disease, chronic lung disease, and somatic NC. Also, I will be just touching some of these diseases later. So next is about the history taking. This is I take this from pediatric protocol, in which we have to inquire about the antenatal history on whether there is a complication of pregnancy, preeclampsia, hypertension, and about the mother, whether she's a smoker or taking alcohol, and any infection during the pregnancy. Also the birth, about the gestational age, birth weight and length, also about the delivery and the place of forceps. It can give some idea what the patient, what the maybe might be having. And also the appeal score. Also any neonatal complication, also developmental milestone can be stunted in child with short stature. And also have to inquire whether the child has been getting enough nutrition by inquiring about the general well-being, appetite, and sleep, also bowel habit, and also pattern of growth from birth, which is important to the definition, important to know what is the pattern so we can intervene early. So about the maternal and child relationship also can cause short stature, and I said so medical history for underlying illness and medication, also history of irradiation, and also in short stature also have a familial causes. So we also have to inquire whether there is a family history of short stature, about 3 generations, and age of onset of puberty in family members of the same sex. So diseases that is running in the family. And next is about the physical examination, also taken from the pediatric protocol. First, we have to measure the anthropometric measurement, which is the height, weight, and also head circumference. Calculate the head velocity, arm span. We will be explaining later. Arm span, also upper and lower segment ratio. 1.7 neonates, slightly less than 1.0 in adults. So general appearance and behavior, and any features of dysmorphism, because in the etiologies that I mentioned before, in some of the syndromes, they have a specific dysmorphism features for each syndrome. Also, at pivotal staging of the patient, so they have been explained by the previous seminar that we have before. So about the arm span, this is how we calculate the arm span. Also, how we want to calculate the upper segment, also lower segment ratio. So arm span, also upper segment and lower segment ratio is important in distinguishing whether the patient is having a familial causes of short stature, or whether there is a pathological or acquired causes of short stature. However, I will not be. You can read about it more later. And next is about the investigation. So about the general test, you can do for blood count, renal profile, liver function test, ESR, also urinalysis. So because it has a wide, the etiology of short stature has a wide array of diagnosis, so we have to patients presented with specific symptoms that might point out, so we have to do general tests to distinguish. Also in syndromes, in most of the syndrome that causes short stature, you have a genetic mutation in the chromosome. So chromosomal analysis is important to diagnose. Also, endocrinopathies can be also the cause of short stature. So in thyroid function, we can do thyroid function test, growth factors in insulin-like growth factor, and also insulin-like growth factor binding protein 3. Also important in diagnosing growth hormone deficiency that I will be explaining later. And also growth hormone stimulation test also important in diagnosing the diseases of growth hormone deficiency. And also under imaging studies, we can do.
Assalamualaikum. Cuba pergi slide tadi.
Causes ada.
Lagi. Cuba explain ni. Explain ni tadi.
Arm span.
Explain balik ni.
So arm span and the segment and lower segment ratio, from what I read on Medscape, is important to distinguish whether the causes, to roughly know what is the causes of the short stature in the patient. If I
Kenapa? How arm span differentiate the causes? You mentioned tadi, so you mentioned something tadi. Terlepas tu saya bising.
I refer back to the, because in diagnosis of patient with short limb dwarfism, they also usually have the upper segment, also lower segment ratio of above than 1.3.
Okay. For age? It depends on age ke apa? What is the normal upper segment, lower segment?
Lower segment usually 1.7.
Upper segment 1.7. Kalau you measure, I ambil you kan, I measure you punya upper segment, lower segment. What is the value?
Close to 1.
To myself.
For adult, no. 1.0. About 1.0.
So should be equal lah kan, upper segment, lower segment should be equal. So usually about 8 years old and above, your upper segment and lower segment should be equal. Tapi before than that, younger children younger than that, which one
upper segment will be higher.
Okay, that's why the ratio will be more than 1.
Yes.
Baby can be up to 1.8, 1.4 lah, best 1.4, 1.6 macam tu. And then it reduce until 8 years old, should be about 1. 8 years old about 0.8 macam tu I rasa. And then later on dia akan jadi 1 lah, 1 until ni. Okay.
Thank you, Dr. So for under imaging studies, we have to assess the bone age by taking the risk radiograph and comparing it to the normal risk radiograph for that age that I will be showing later. And we also can do CT and MRI brain, as one of the causes of the short stature can be due to pituitary adenoma. So to diagnose, we can see the features of pituitary adenoma on the CT and also MRI brain. And for others tests such as blood gas analysis, it is known that one of the rare causes of short stature is the renal tubular acidosis. So to identify that, we have to do the blood gas analysis. And also radiograph of spine is helpful in ruling out with patient with any skeletal dysplasias. So these are some of the terminologies that we have to understand. So in order to understand the diseases of the short stature, So the chronological age is the actual age of the child, and the height age is the age at which the child, and the height of the child is at 50th centile, and the bone age is an indicator of skeletal maturation. So even though all these terminologies have age in their name, but all of them can be different, and also some of them can be normal, while others are not normal. So maybe the chronological age of the child is at for example, at 8 years old, but the bone age is actually younger than that. So that means that even though the child grow to the age of is currently at the age of 8 years old, however, the bone age is unfortunately immature or younger than the chronological age. So these few pictures I got from the atlas of the bone age. We can see that this is a picture of as the age is different between boys and girls. Also, the radiograph, the risk radiograph in boys and girls also different, and also have a different in terms of the age. So this is the risk radiograph, hand radiograph of the 12 months old boy, and also a 24 or 2 years old boy. So the comparison or the bone age assessment is made by comparing the chart at the patient radiograph and also the atlas. So this is for the bone, and these are for the girl also at the same age of 12 months old and also 24 months old. Okay. So this next few slides just be touching not too deep about some of the diseases that can cause short stature, because if I go too deep in every disease, the presentation will be longer. Okay, so first is about the growth hormone deficiency, and as we know that the growth hormone is responsible for the normal development of the children. However, we know that the growth hormone is secreted by the anterior pituitary. So if there is a disruption of the growth hormone, it can be in the higher brain or in the hypothalamus or the pituitary itself. And the deficiency can be congenital or also acquired. And the child can be presented with severe growth failure, delayed bone age, also there is an increase in the weight-height ratio. Yeah, so the child might be too much weight for its normal height. So maybe the child have more weight for more than what the child has supposed to be with that height. So the diagnosis is a combination of the clinical assessment, as I mentioned before, the investigation about the insulin growth factor, insulin-like growth factor 1, insulin-like growth factor binding protein 3, and also assessment of the bone age. And next about the Cushing syndrome, also due to excessive cortisol release and increase the weight and also the growth retardation, and also have an excessive weight for height ratio, and it can be due to ACTH secreting pituitary adenoma and also adrenal adenoma. And to diagnose, we have to do the 24-hour urine collection for cortisol or dexamethasone suppression test. And next are there's a few syndromes such as Turner syndrome and 45XO. This patient can be presented. These are the some of the features that the child can present. Short stature with of the neck, low posterior hairline, can also have a contraction of aorta, broad chest and widely spaced nipple, cubitus valgus, infertility, pigmented nipple, also peripheral lymph edema. And next is also Down syndrome. So can be presented with gross stature and all these features. Cross-failing, sorry. Prader-Willi syndrome is caused due to chromosome 15 deletion. And other than this is some of the facial features that the patient can have. Also, apart from failure to thrive or the short stature, patient also can present with hypotonia, hypogonadism, also developmental delay. And lastly, Dominant syndrome, which is an autosomal dominant cause, is associated with congenital heart disease, which is pulmonary stenosis. And these are some of the facial features and signs and symptoms that can be found on the patient. So just gonna touch about the management generally. So if the short stature is caused by an underlying cause, such as hypothyroidism and uncontrolled diabetes mellitus and other chronic illnesses, so it is logical for us to treat the underlying causes first, and then only the problem of short stature can be cured or solved. Also, in child with a non-treatable cause, such as in genetic or familial short stature, constitutional delay, or of growth and puberty, so the child might need help in psychological support. So psychological support can be of a help to these patients. And also, there's a role of growth hormone treatment indicated taken from pediatric protocol. It's indicated in pediatric growth hormone deficiency, Turner syndrome, Prader-Willi syndrome, and also idiopathic short stature. These are some of the indications. There's also a few other indications that can be found on the pediatric protocol. So the next is how the growth hormone treatment initiated according to the pediatric protocol. So these are the doses and also the frequency of the growth hormone treatment, somatropin, and the side effects and how the monitoring of the patient should be done. So that's for the short stature. And next, about tall stature. So according to Nelson Textbook of Pediatrics, 21st edition, it is height above 97 percentile for age and sex of more than 2 standard deviation above the mean of for a defined population. So our definition of tall stature in Malaysia can be different to what they are defined in the West or in the European countries. The etiology also can be divided into fetal overgrowth, non-endocrine, also endocrine. The fetal overgrowth can be due to the maternal diabetes mellitus, which can cause pressure the born child to be macrosomic. So Sotos syndrome, and non-endocrine can be due to the familial Marfan syndrome, inflammatory syndrome, also exogenous obesity, and under endocrine can be due to excess growth hormone secretion due to adenomas, X-linked acromegalism, and also hypothyroidism. And one of the common cause of tall stature is familial tall stature, which is a variant of normal growth development. So as it is a familial cause, so it is important to calculate the mid-parental height because maybe the parents also having is also a tall person. So if we calculate the mid-parental height, so it is normal for the child to have such height, because the parent is also a tall person. So it is important to acquire about the family history of tall stature. And we have also to confirm there is no dysmorphic features of the patient. And the height velocity are still in the normal range, but in high normal range. In this, there is a 6 centimeter per year between the age of 6 years and so puberty. And we also have to assess the bone age, and it should be normal. Only then we can say that the patient is having familial tall stature. And next is due to the excess secretion, which if there is occur in children, if there is an open epiphysis, it is called gigantism. And if it occurs in adult with closed epiphysis, it is diagnosed as acromegaly. And these are some of the features of gigantism, which are the longitudinal growth acceleration, patient with large hands and feet, have a coarse facial features, and also rapid growth of head. So this illustration is a simple illustration that can differentiate between gigantism and also acromegaly. So gigantism usually happen, not usually, gigantism happen in children, while acromegaly is in adult. Both is caused due to the growth hormone excess. So the best confirmatory test for acromegaly is the oral glucose suppression test. So that the glucose will not suppress the growth hormone. And next is the Klinefelter syndrome. It's the 47XXY. The patient is tall and thin, and these are some of the features that can be found in the patient. Reduced facial hair and body hair. Patient will develop gynecomastia, osteoporosis, have a feminine fat distribution, and also somatostatic hypergonadism. And next is the Marfan Syndrome, an autosomal dominant disease, and it's a genetic defect of connective tissue. Some of the features can be found on patient with Marfan Syndrome. And the investigation, so it can be divided into laboratory imaging, also this investigation. So as similar to short stature, one of the possible causes is the endocrine causes. So we can do TSH and T4 test to level to assess whether the patient is having hyperthyroidism, and also the level of the insulin-like growth factor 1, which will be high in patient with acromegaly, also gigantism. And patient with serum, patient can also present this presentation also can be due to precocious pivotal problem. So it is normal to rule out the pivotal problem through serum LH, FSH, and also testosterone level. And also it is important to do the growth hormone test, serum cortisol, also serum prolactin, because in serum cortisol and serum prolactin can be high due to in pituitary adenoma, which is the causes of the growth hormone excess. So the pituitary adenoma will not just will increase the level of growth hormone, also it will increase the level of cortisol and also prolactin. So we have to assess those hormones. And imaging, the risk radiograph to assess the bone age. I mentioned before, the MRI of brain to exclude the pituitary adenoma, and similar to the short stature, karyotyping to diagnose the syndrome, and also the visual field examination, in which it will be affected in patient with pituitary adenoma. As the mass of the pituitary will affect the optic chiasm and cause visual field disturbance. And lastly,
what type of defect in visual field you expected in pituitary adenoma?
Bitemporal hemianopia.
Okay, good. So apa maksud dia bitemporal hemianopia? Loss of which part of your vision?
Outer vision.
Temporal side of vision kan, bilateral temporal. Maksud dia lateral side of bilateral eye tu loss lah, visual field dekat bilateral lateral visual field. Okay.
Yes.
Okay. Dan habis kan?
Tinggal management.
Okay kan. Management itulah tak apalah. You 5
Yes.
Cepatlah. Okay lah.
Okay, so for last part is the management. So as I just been talking about the especially the growth hormone excess. So we can give the octreotide, the somatostatin analog, to suppress the growth hormone production. That has a significant gastrointestinal side effect. And other, we can use the pepvisomel, which is a selective growth hormone receptor antagonist that will compete the endogenous that will compete with the endogenous growth hormone to the binding to the growth hormone receptor, and also will suppress the GH production. And also we can, in children, we can give hydrosteroid to promote epiphyseal closure. So that's all for my part. Yeah.
Okay, any questions? I think there's a few there's a few misconceptions. Any questions? But before that, any questions?
I have one question. I don't quite understand about. So is it normal if the bone scan is lower than the normal age?
When we can say this is abnormal, does it has to be umur 2 tahun, bone age 2 tahun? So how if the bone age is 1.5, umur chronological age is 2 year old? Is it abnormal?
Yes.
Presenter, so
the bone age should be, but there is some cases that it is called constitutional. So the bone age is delayed, but it is still abnormal. So it is abnormal.
Yeah. So bila kita normal, does it has to be exactly the same as your chronological age?
Should be same.
No lah, dia ada leeway kan, dia ada plus minus 6 months macam tu. So dia ada plus minus about 6 months. So because nothing is fixed in this world, because at the end the assessment of the X-ray of bone age is very subjective. There's multiple ways to assess lah. There's about 2 ways. The most established is about 2 ways. One using Atlas, the other one using software. You can using their software. Even Atlas pun ada 2 Atlas, and then software ada software dia lah. And this has to be done by pediatric endocrinologists only, or by pediatric radiologists trained in bone age assessment. Yang baru you boleh assess bone age. Okay, next question. Ada lagi questions? Awesome. Okay, okay, actually there's one, I think a bit misconception. Go to your first slides. I'm going to spend a bit on this, and then the rest, the other two topik I tak minat. So kita boleh go through very quick lah. The first slides. No, IM is my my interest lah, tapi tak apalah. Look at the second slide, sorry, third slide, this one. Okay, can you, okay. So if you look at this kan, the most important period of growth is actually during infantile, okay? Infantile and also fetal. Okay. So what are the factors contributing to the growth during this period? Nutrition kan? So usually, okay, during this period, we don't use the term short stature. No, and you cannot diagnose short stature using the WHO punya growth chart yang 2 years old and below. If you want to diagnose short stature, you kena guna CDC punya growth chart yang stature for age ataupun yang height for age atau weight for age or stature for age. Because dia ada the implication of your diagnosis is when you say someone a short stature kan, so what is the management?
Growth hormone.
Growth hormone kau. So nutrition will not play any role in short stature. So that's why diagnosis of short stature can only be given in a child more than 5 years old. Faham tak? Kalau you ada satu baby baru setahun datang to you, referred as short stature, this is not short stature. You cannot diagnose short stature because the diagnosis would be stunted ataupun gross faltering. Failure to thrive kalau dia globally lah. Tapi usually we call it stunted, gross faltering ataupun wasted. These are the term yang kita, because it reflects nutritional status. Short stature ni doesn't reflect nutritional status. In fact, nutrition has no role. So after 5 years old, then only you will diagnose as short stature. And diagnosis of short stature not by simply plotted on growth chart. Dia not based on growth chart. Dia mesti correlates. You mesti plot against dia punya height potential, which is mid parental height and height potential. Because remember, after short stature, the implication is genetic and also endocrine. Faham tak? So kalau father dia, parents very tall, then chances are the child will be tall. So kalau child too short atau parents short, then chances are the child will be short. So it has to be plotted against the mid parental height ataupun height potential. Later lah kalau ada masa ayah ajar, kalau kita jumpa, you boleh tanya me. You can ask me how to plot, how to assess the height potential ataupun the parental height. Definitely not online lah. Okay, faham tak? Faham tak? So in young children before 5 years old, you cannot diagnose short stature. Dia similarly like development tau. Development pun sama. Below school age kan, you tak boleh kata dia slow learner ataupun low IQ. You akan kata dia global developmental delay. Tapi once they reach school age kan, 7 years old, 6 years old, you can actually label them as, you won't call them global developmental delay, you will call them slow learner ataupun low IQ. Learning disable. Okay, faham tak? Okay. Any more questions?
Doctor, I have question. So when we will calculate the mid-parental, when we will use the formula, because the formula mid-parental height is based on adult height, right?
Bila, okay, you got a child kan, more than 5 years old, and then you plot growth chart dia, stature for age low, nampak dekat below below 5th percentile lah. Then you have to plot the mid parental height. Okay, and then you from mid parental height you will decide the height potential, which is 2 standard deviation above and below mid parental height, which is about 10 cm. Then only you can decide. Kalau dia punya plotted to lower than that, then you akan kata this is short stature lah. Tapi kalau dia within the height potential, then you tak boleh lah kata dia short stature. This is normal height untuk dia. Because dia punya genetic potential is only that. Faham tak?
Okay,
Faham?
thank you.
Faham kan? Okay. So ada soalan lagi? Okay, kalau tak ada next lah. Continue next, IM.
Okay. So continue on my part. Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Arif and I'll be presenting on inborn error of metabolism. Next. So inborn errors of metabolism is a congenital metabolic disorder as a result from absence or abnormality of an enzyme or its cofactor yang lead to either accumulation or deficiency of a specific metabolite. So IEMs are transmitted usually by autosomal recessive or X-linked. So you can see from the picture, from the diagram that I give you, the problem is when there is abnormality or deficiency in enzyme or cofactor. So substrate B that's supposed to become substrate C or D will have failure to become with the pathway, and it will in turn either remains as substrate B or becoming substrate E. for an alternative pathway. So the problem of the disease may arise due to accumulation of substrate B and E, or maybe due to deficiency or lack of substrate C or C and D. Next. So I hope you understand that a little bit, that the problems is due to absence of abnormality of enzyme or cofactor. So epidemiologically, so the IEMs is around 1 in 800 to 1 in 2,500 live births worldwide. The statistic in Malaysia I cannot find, but I concur that it is the same, almost the same as this statistic. There are over 500 human diseases due to IEMs, and they are recognized, and a significant amount of them are amenable to treatment. And these are the list of common types of IEMs in Malaysia. The most common such as G6PD, maple syrup urine disease, methylmalonic aciduria, propionic aciduria, UCD, phenylketonuria, mucopolysaccharidosis, and mitochondrial disease. Next. So IEMs can be further classified into 5 groups based on therapeutic perspective. The 5 useful groups are: the first one are the disorders that give rise to acute or chronic intoxication. The diseases such as includes aminoacidopathies such as MSUD or phenylketonuria, and also tyrosinemia. And usually they are, for group 1, they are readily diagnosed through basic IM investigation, such as due to blood gases and others. And special emergency and long-term treatment available for most of the diseases in group 1. Then we have group 2, which are disorders with reduced fasting tolerance. Some of the examples are glycogen storage diseases, disorders of gluconeogenesis, or others. And it is usually a persistent and recurrent, it is first diagnosed when there is persistent or recurrent hypoglycemia. And then specific emergency and long-term treatment are available for these diseases for group 2. Then we have group 3, which are neurotransmitter defect and related disorder. So, some of the diseases such as non-ketotic hyperglycemia, serine deficiency, and others, or GAP and others. And diagnosis requires specialized CSF analysis. Some are treatable for group 3. Next. Next, we have group 4 and group 5. For group 4, there are disorders of the biosynthesis and breakdown of complex molecule. The examples such as lysosomal storage disorders, as they are diagnosed with specialized diagnostic tests, and very few are treatable. And then lastly, we have mitochondrial disorders, such as respiratory chain enzyme deficiencies, and they are first presented with diagnosed when there is persistent lactate acidemia. And it is usually mostly we can only offer supportive care for group 5. Next. So the approach for patient with IEM, so child with IEM, usually we have clinical suspicious. We are clinically suspicious when their child is when there is an acutely ill child when there is an acutely ill child, and we also need to consider other diagnoses. In all, we also suspicious when for neonates with unexplained, overwhelming, or progressive disease, particularly after normal pregnancy or birth. They are normal but deteriorates after feeding. And then IEMs is also for any children with acute encephalopathy, particularly preceded by vomiting, fever, or fasting. And also in all children with unexplained symptoms and signs of metabolic acidosis, hypoglycemia, acute liver failure, or Rayleigh syndrome. Next. And also clues for the diagnosis of IEMs. First of all, if there is an unexpected death among the siblings of the patient due to sepsis or SID or unexplained death, and then unexplained disorder in other family members, such as mother having HELLP syndrome or progressive neurological diseases. If there is consanguineous marriage, especially among their parents, and then deterioration of the after a symptom-free interval in newborn, and then if patient having coming with unusual smell, usually burnt sugar smell for MSUD or sweaty feet in isovaleric acidemia. Next. So for the history that we need to for the history that we can get from the patient, usually we want to identify the onset. First of all, we want to identify the onset of the symptoms, where if the patient the symptoms arises after feeding or any change in diet or fasting, and if there are neonates who are sick after previously well, and then if the patient, especially for type group 2, yang presented with hypoglycemic symptoms, so for the symptoms such as lethargy, irritability, or fasting intolerance. And usually, Iems will presented with gastrointestinal symptoms or neurological symptoms. The gastrointestinal symptom may include vomiting or dehydration, poor feeding, failure to thrive, decreased GI motility, hepatomegaly or hepatosplenomegaly, or jaundice. Neurological symptom, lethargy, coma, seizures, developmental delay, or ataxia or dystonia. For other than that, we need to also identify acute metabolic decompensation symptoms, which is the emergency urgent signs that we need to identify. Some of them these are repetitive from the others, such as vomiting, anorexia, or failure to feed. However, it is important for us to identify them so for immediate management. So they may be presented with vomiting, anorexia, or failure to feed, lethargy that can progress to coma, seizures, rapid deep breathing that can progress to apnea, hypothermia, rhabdomyolysis, or unexplained infant death, or a brief resolved unexplained event. A brief resolved unexplained event is a condition where an event when the infant is characterized by marked change in breathing, tone or color or level of responsiveness. Usually duration less than 1 minute, whether around 20 to 30 seconds, and then we will return back to baseline. Next. So the physical examination that we can see for the Iems, usually not much can be, Iems can be very, is very wide and very variable. However, the symptoms that we, the sign that we may see are such as altered mental status, abnormal vital signs, unusual smell, facial dysmorphism, jaundice, abnormal hair or organomegaly, and hypotonia. Next. Next, for the investigation that we will do for patient, usually initial findings will include poor feeding, vomiting, lethargy, all the symptoms that I said just now. The diagnosis in mind that we need to keep in mind, it may be to Iems, or also it may be due to infections, trauma, or any CNS abnormalities. So for if we were able to exclude any sepsis or infection, then we need to see if there we need to bear in mind that Iems may be a cause for current presentation. So for metabolic disorder, we will try to obtain the plasma ammonia, and then from the value we will identify with based on the anion gap to see which group of the defect may be arising from. Either it's urocycle defects, organic acidemias, or aminoacidopathies. So this is the basic and special metabolic investigation for Iems. Usually, the investigation that is put in here that I put here usually will pick up most of the disease from group 1 and group 2. The one that is can be treated that the treatment or the management is outlined. So for basic metabolic investigation, we will see for blood count, electrolytes, ALT, for the liver enzymes, CK, creatinine, urea, uric acid, and coagulation. And must include in the workup is ammonia level, glucose, lactate, blood gases, and ketostates. Okay, ammonia I put in the next slide the reference level. Then we have special metabolic investigations such as acylcatenanes, amino acids level, organic acids, and orate. So, okay, next. So for this is the useful or abnormal, useful, normal or abnormal values. For ammonia, usually in units, we will suspect Iems if the reading is 200 micromole or more. And after that, we will also suspect for neonates after the neonatal period if the Iems is 100 micromole or more. However, we need to note that the rise in ammonia level may be due to false elevation if blood sample is not analyzed immediately, or maybe due to secondary elevated, maybe due to elevation due to severe liver failure. And then gas calculation is sodium plus is this one. Normally, usually in 15 to 20 millimole, and yeah, and then we for lactate level in blood 2.4 and CSF 2.0. Okay, next. Okay, this is the disorder typical of this disorder for basic.
Sorry.
Eh?
For the iron gap just now, doesn't the formula seems a bit? We should add the chloride and bicarbs, right?
Add. This one I got from this protocol.
Between sodium,
No, this is
potassium,
correct.
and
This is correct. So it's sodium plus potassium minus chloride plus plus bicarb.
chloride plus bicarb. There's a
Ini betul
typo.
lah ni.
Betul lah.
No, it's betul.
Okay.
Negatif.
Kalau kita letak kurungan besar dalam chloride dengan bicarb tu jadi positif lah. Yang ni sebab dia tak ada. Okay.
Tak ada kurungan, so dia
tolak chloride, lepas tu dia tolak bicarb lagi.
Yalah, sebab tak ada kurungan dia jadi pelik.
Okay. Salahkan.
Okay, right.
Okay. Continue. Okay, this is the finding for certain diagnoses such as disorders such as urea cycle defects, where they will have high ammonia, normal glucose, and others. You can see this later. Next is for the emergency of management for sick child with IEM. There are 3 steps for the emergency management. First of all, we need to see from the basic investigation result and clinical finding. Usually, the emergency management is very useful for disorders of group 1, or maybe useful for disorder for group 2. We want the aim is we want to promote anabolism and initiate detoxification measures. Sorry, tak clear sangat tapi I will read it. Okay. First of all, we will immediately stop any protein intake, maximum within 48 hours, and we will try to correct the hypoglycemia and metabolic acidosis. Second step is we will give adequate calories intake, where we aim for 120 kilo. We will give adequate calorie intakes. We can help by giving IV glucose or intralipids, and intralipids. And then lari lah. Okay. Sorry. Saya kena tengok balik slide saya sebab yang dalam ni lari.
tak apalah, you just present je lah. You want to listen to your presentation, bukan your slides. So tak apa, present je.
Okay. For the next, we will try to identify if there is any problem with the. We will try to identify the effects or the side effects of the IEMs itself. If patient coming with hyperglycemia, then we will give insulin. If patient coming with IV fluid devolute, then we will give diuretics, IV furosemide. If the patient coming with electrolyte imbalance, we will titrate serum sodium or potassium. And if the patient coming with protein malnutrition, we will add IV vitamin or milk after 48 hours. Then we will need to see for any other complications such as respiratory problems, where if such problem arises, we will give artificial ventilation. if patient coming with septicemia, we'll give antibiotics, and cerebral combustion, we'll give anticonvulsant. If there is cerebral edema, we will avoid fluid overload, and we will hyperventilate patient, and we will give furosemide and mannitol, and also we will try to get early central line. Next. This is the level that will help for acute management, especially for the first one is for ammonia level. So we will help a patient by either by giving hyperammonemic drug cocktail for patient with ammonia level of 200 or coming with symptomatic encephalopathy. We will give loading dose either benzoate or phenylbutyrate, and loading dose and then maintenance dose. Then for dialysis, the indication usually if the ammonia level is more than 400 or patient with symptomatic encephalopathy, and then if there is inadequate reduction despite giving drug cocktails, so we will opt for dialysis. For MSUD, so we will opt for dialysis if there is any indication of losing more than 1,500 micromole or patient with symptomatic or encephalopathy. And then organic aciduria, also we will give dialysis if there is any intractable metabolic acidosis or symptom if patient is having encephalopathies. Next. So for that one is for step 1. Then for step 2, the aim is for adaptation and specification of therapy according to special metabolic investigation of definitive diagnosis. So if patient coming with for patient with protein metabolism problem, the long-term management we will give specific precursor free formula or natural protein or breast milk or infant formula if the patient is tolerable. Then other long-term treatment, we will give oral anti-hyperammonemic oral anti-hyperammonemic drug cocktails for Uracil Effect, carnitine for organic acidurias, vitamin therapy in vitamin-dependent disorders, and we will need to transfer to Metabolic Center for optimization for long-term therapy. Next. Lastly, for step 3, we need to be prepared for future decomposition. So the patient is currently safe. So in the future, we wish to have clear instruction for the parents to if patient coming with symptoms again, and then we will give full supports for parents. Provide a letter that includes emergency management protocol to be kept by the parents, and then rapid action strategies when child in catabolic distress. Usually, rapid catabolic stress may be due to patients themselves having infebrile state or patient going through for surgery. Next, are the importance IEMs. First of all, I highlighted 3 types of 3 groups of IEMs, which are aminoacidopathies, and then urea cyclic defect, and also organic acidemia. First of all, for aminoacidopathies, there are 2 diseases that I highlighted here, which are phenylketonuria and also MSUD. For phenylketonuria, it is due to phenylalanine hydroxylase enzyme deficiency. And then due to this deficiency, there will in turn result in excess plasma phenylalanine and decrease in tyrosine. So excessive plasma phenylalanine, more than 1,200 micromole, will in turn be converted to phenylpyruvate and later phenylactate and later phenylactate. And then this will in turn give the urine, the presence of phenylketonuria in urine will give the fruity odor. Excessive plasma phenylalanine will saturate in amino acid transporter in BBB, and then it will in turn inhibit intake of tryptophan and tyrosine that is required for neurotransmitter synthesis. So this is the reason that it will cause the complication of this. Okay. Next is the clinical features and diagnosis. So for clinical features, usually a child with phenylketonuria will have intellectual disabilities, and it will be gradually developed over time and presented with fruity or the urine, vomiting, and psychiatric disorders such as ADHD or ASD, and developmental delay. For screening, we can do tandem mass spectrometry, diagnosis through serum phenylalanine level 1,200 micromole, and management is we give phenylalanine low diet. Next is MSUD, maple syrup urine disease. It is due to deficiency of branched chain alpha keto acid dehydrogenase. And in turn, as a result of this, there will be lack of catabolism of valine, leucine, and isoleucine, the branched chain amino acid, and the accumulation of the branched chain amino acids is the one that's causing the problem. Next, there you usually will come with clinical features of poor feeding, lethargy, convulsion, and coma, cerebral edema, hypertonic, and opisthonatus posture. This one is the one that is macam C-shape tu yang. Okay, and then death usually occurs after weeks or months if untreated. Diagnosis is usually by amino acid analysis, elevated serum branching amino acid, enzyme assay, neuroimaging for cerebral edema in acute setting or cerebral atrophy in chronic. Usually, next, the treatment for MSUD, usually for acute, we will give hydration to promote diuresis so that the branching amino acid can be removed. And then we also, if the just now in the table just now, there is the level for dialysis 1,500 if I'm not mistaken, and then IV mannitol and hypertonic solution, and then adequate calorie intake.
Okay.
So treatment for chronic, usually if we will restrict branches.
Tak payah visit, kenapa? By feeding lah. Tapi kena check gula dia.
Okay, for branches amino acid, why MSUD is important is because branching amino acid can cross blood-brain barrier and metabolize to glutamate and glutamine, which in turn causing excitatory continuous neuron firing and exhaustion. Next. Next is the Uracil Effect.
Yeah, saya boleh laju je lah. Sorry, saya boleh laju lah sama yang sangat lama ni.
Okay.
Just one slide. Go to something.
So for Uracil Effect, it is due to the problem with just now due to the enzyme and cofactors problem, right? So hyperammonemia type 1, you can see in the diagram the number 1, CPS deficiency. And then hyperammonemia type 2, number 2, ornithine OTC. And then citrullinemia due to number 3, arginine succinic acid synthetase deficiency. And then arginine succinic aciduria, number 4. And then number 5 in the graph, hyperarginemia due to arginase deficiency, number 5. Okay, so usually urea defects presented clinical features for neonates. Usually symptoms started after feeding, where they will have lethargy, irritability, vomiting, convulsion, coma, and proton. And so for cerebral edema, due to hyperammonemia. And then infants and older children may come with ataxia, mental confusion, later on agitation, combativeness, irritability, and lastly coma. And then for investigation, we identify them usually by elevated ammonia level and normal anion gap, and then plasma amino acid measurement. Then we do enzyme assay to identify which level of Uracil Effect is, and also gene study. And lastly is for next is for the management, which is for the acute management. This one is the table that I put just now for antihyperammonemic drug cocktails dengan dialysis just now. And then this is for acute. And then for long-term management, we will give protein restriction and then chronic administration of benzoate or phenyl acetate or arginine or citrulline, depending on the types of or the level of the Uracil Effect. Next is organic acidomy. The last one is organic acidemia. So the diseases that I put here is propionic acidemia. It is characterized by deficiency of propionyl-CoA carboxylase, an enzyme involved in breakdown of amino acids. And lack of this will in turn reduce the conversion of propionic acid to methylmalonic acid. Next. Usually, the patient will come with symptoms of poor feeding, lethargy, vomiting, convulsion, and coma, and metabolic acidosis. And also, will also come with neurological sequelae such as pyramidal and extrapyramidal deficit. The patient will also have intellectual and developmental delay. Next, we have investigation. For investigation, we will identify by high or elevated serum ammonia, and then large anion gap, and then plasma valine, isoleucine, and leucine will be reduced, and then high concentration or level of propionic acid, serum propionic acid, and from CT and MRI we can see atrophy or demyelination of basal ganglia. Lastly, for the management, for acute management, we will give hydration and keep in view for dialysis if necessary, hydration for diuresis. Next is we want to treat metabolic acidosis and hyperammonemia, and also constipation. And we will also ensure adequate calorie intake. For long-term management, for chronic, we will give L-carnitine supplementation and also protein restriction. So that's all from me.
You got questions? If you look at the slides kan, ada 3 amino acids that keep on mentioning. Apa dia?
The branch shape.
Appear again and again. The branch amino acid. Apa dia? What are the branch amino acid? Leucine, isoleucine, and valine kan?
Valine.
Multiple time it appears kan? Why it's so important? Why
Because
this 3 branch amino acid is important? What is branch amino acid?
Because when it is when there is accumulation of the branch chain and it will in turn may cross the blood-brain barrier, and then it will cause the it will be metabolized to glutamate and glutamine, and then they will cross BBB and causing excitatory or neuron firing and neuron exhaustion.
Okay lah, that's for ni lah, itu kat MSUD. Okay, so in general the problem is, okay, amino acid is a very simple, it's the simplest form of protein kan? Okay, in fact you only absorb amino acid. So you are the essential amino acids, you have non-essential amino acids. Problem is branch amino acid is a complex amino acid, slightly complex, more complex than the simple amino acid, like tyrosine semua. So all these, the 3 amino acid, you need enzyme to convert the amino acids to the branch amino acid. So a lot of problem, especially in organic acidemia, occur in that area because you don't have the enzyme to branch the amino acid. So that's why valine, alanine, isoleucine, valine, leucine, and isoleucine is one of the main metabolites and also substrates that involve in a lot of IEM. Okay. However, and a lot of IEM will lead to accumulation of these 3 amino acids ataupun lack of these 3 amino acids. The problem is, siapa tahu ni memang pandai lah. Which one of these is essential amino acid? What do you mean? Do you know what is essential amino acid?
Essential meaning that we need to eat. We need to get the essential from the diet.
Because we cannot
make it
produce
ourselves.
it. Okay? Okay, we cannot make it ourselves. So one of these 3 is essential amino acid. We cannot make it. So if you stop eating this, I mean, if you do not consume this amino acid, because you need it in your diet, from your diet, So that's the tricky part lah. Because a lot of condition you get accumulation of these three amino acids, but one of the amino acids is required. You need to eat it. If not, you cannot form your protein everything. So nanti baca lah which one of the three yang essential amino acids, and how much you have to consume this ni, and too complicated lah later in the management of IM. If you want to focus on IM, then you read about this lah. Anyway, ada questions lah? Ada any questions about IM? I think what important kan, yang at your level, what important is you need to know signs and symptoms of IM, when you have to suspect IM, in what case. Some of the common IM are type 2. What is the mode of inheritance? OTC, in fact, is the commonest UCD. OTC deficient. OTC deficiency is the commonest urea cycle defect. In fact, you see that's the only one urea cycle defect that you'll be seeing in your life lah. Maybe you see the rest a bit CTC semua tu, but OTC is the most common. And what is the mode of inheritance? Siapa tahu?
Is it autosomal recessive?
No, OTC is sex-linked. The sex-linked recessive. The X-linked. So OTC is X-linked. So you akan dapat history of a boy, lahir well, very well, athletically, uneventful. And then after a few hours of life, started to become less active. And then poor feeding, and then seizure. This is the typical story of OTC lah. And then when you ask the mother, he lost 2 or 3 of the elder brothers, died at infancy or died at very young age. This is very typical story of OTC, because OTC is relatively common compared to other UCD lah, urea cycle defect. So you need to know the inheritance, things like this lah. But for those yang common, like MSUD is very common. It's one of the commonest IEM. You'll see MSUD lah. I've seen like few 3, 4, 5 macam MSUD, you know, because they live long. If you manage well during neonatal period, they can survive until adulthood. And a lot of them have normal IQ. I've got an MSUD girl yang score straight A pun dalam SPM. A very good swimmer despite diplegic. And because BBB kan, because of the 3 amino acids, so the branch amino acid, the cross blood-brain barrier, so almost all MSUD children, dia akan ada CP, usually diplegic CP. So these are the things yang you kena read about, rather than you read about the detail metabolism, which is very good for you to know, but a lot lah to read, nama enzyme kan. Tapi at your level, you need to know just the description of the disease. For example, if you got a child kan, datang kat klinik, datang dengan diplegia. So what are the usual cause of diplegic CP? Anyone? Kalau patient datang dengan diplegic, kalau you nak guess kan, what is the cause of diplegia? Usually apa? HIE tak cause diplegia. HIE cause quadriplegia kan. HIE is the global ischemia of the brain. Kalau diplegic, selalu dia punya problem dekat mana? Homunculus. Kalau you got a child with diplegia, usually they insult dekat mana? You ingat kan, you punya brain homunculus kan? Diplegia means lower limb worse daripada upper limb kan?
Yes.
Kan diplegia. Kan, betul tak?
Yes, betul.
Ha?
Ya, betul.
Kan? So dia punya problem dekat mana selalunya?
Cerebral cortex, dekat homunculus
Dia
leg.
punya lower limb dekat mana?
Dekat upper.
Lah, leg punya homunculus dia situated kat mana? Dekat center kan? Dekat near to the fissures kan? Betul tak? Lateral is you punya upper limb. Betul ke tak? So what structure yang ada dekat tengah-tengah in baby? You ada ventricles kan? Betul tak? ventricle, third ventricle semua kan kat tengah-tengah brain. Kan? So patient yang macam mana yang akan dapat insult dekat that area?
Ventricular locomalacia.
Meningitis.
Good. Patient PVL lah. Meningitis usually dia datang dengan hydrocephalus and then CP dia jarang lah diapija. Usually is either, kalau meningitis ni biasa is quite global. Because apa? Obstruction kan. Obstruction dia compress the whole brain. Tapi usually is extremely premature baby yang ada IVH kan, intraventricular hemorrhage atau PVL, periventricular leukomalacia. So these are the population yang datang dengan diaplegic CP. And another population yang datang dengan diaplegic CP is MSUD. Things like IEM dia akan datang dengan diaplegic CP. Because dekat mana you punya blood-brain barrier? Blood-brain barrier kat mana? You can baca. Tak apa, you baca lah nanti. Bosan lah, hijau. Okay, you baca.
Dekat correct plexus ke?
Dia mesti dekat cord plexus. Cord plexus dia produce CSF kan. CSF you dia mengalir, dia masuk mana?
Ventricle.
Okay, ventricle. So daripada ventricle macam dia pergi ke you punya spinal cord, spinal column, and then dia pergi ke blood. So you kena tahu the anatomy lah, where dia punya laluan semua. Apa dia punya foramen, yang tu you kena tahu anatomy lah. Anyway, so by knowing the anatomy, so basically dia akan accumulate, dia akan circulate dekat your ventricle area kan. So dekat center, betul tak? Center. So dia akan deposit the branch amino acid ni, BCAA ni, dia akan accumulate dekat along the center tau. So dia akan cause diaplegia. So this another common population yang akan datang dengan diaplegia. So you nampak patient diaplegia, chances are you boleh bet 90% of time diorang ni is actually extremely premature baby. Kalau tak, they are usually the IEM punya baby lah. Okay, so dia akan datang dengan diaplegia. Kalau paraplegia, kalau quadriplegia biasanya is HIE lah, the most common. Kalau bukan HIE, meningitis, benda yang global lah, global insult atau MVA. Things macam tu akan cause global insults. So this will cause patient yang drowning, yang ni boleh dapat quadriplegia. So this is how you read lah. So you have to correlate clinical and your theory. Tapi this need training and also experience lah. Anyway, so let's move on. Ada soalan ke? IEM is very interesting. One of my favorite topics, but it's difficult lah, of course. Okay, ada soalan? Kau tadi tu move on lah. Okay, next.
Okay.
Oh, ni lagi bosan. Okay, please.
Yeah, Assalamualaikum warahmatullahi wabarakatuh. So I'm Azib. So today's the last teaching seminar. Topic is on sepsis and septic shock. So next slide. So there's my outline, definitions of several terminologies, pathophysiology, risk factor and clinical features, as well as investigation and management. So next. So infection is defined as suspected or proven infection caused by any pathogens. So it is also clinically defined as a clinical syndrome associated with high probability of infection. For example, petechiae or purpura in a child with hemodynamic instability, or fever, cough, hypoxemia in patient with leukocytosis and pulmonary infiltrates on chest radiograph. So for diagnosis purpose, it is proven by positive culture, tissue staining, or PCR test. Next. Okay, so next is on systemic inflammatory response syndrome, SIRS. So it is defined as a widespread inflammatory response that may or may not be associated with infection. So in order to diagnose, we need at least 2 out of the following criteria, of which one must be from abnormal temperature or leukocyte count. So from the table, we can see the temperature, either hypo or hypothermia, heart rate, we have tachy or bradycardia, respiratory rate, as well as leukocyte count. So respiratory rate, mean respiratory rate more than 2 standard deviation above normal for age, or mechanical ventilation for an acute pulmonary process. And for leukocyte count, elevated or depressed for age, or more than 10% immature neutrophil. So next. Sepsis is when there is presence of SIRS plus the presence of suspected or proven infection that constitute sepsis. And then we have severe sepsis, which is considered when it is associated with cardiovascular dysfunction, acute respiratory distress syndrome, as well as dysfunction in 2 or more of other organ system. And then we have septic shock, which is severe sepsis plus persistence of hypoperfusion or hypotension despite adequate fluid resuscitation or a requirement for vasoactive agents. So next. So these are the criteria or parameter that define each of these. So for a cardiovascular dysfunction, it is the criteria is hypotension or a need for vasoactive drug to maintain the blood pressure, or 2 of the following. For example, unexplained metabolic acidosis, increased lactate, oliguria, prolonged CRT, and core to peripheral temperature gap more than 3 Celsius. For RDS is when the partial oxygen over fraction oxygen ratio less than 300 millimeter mercury, bilateral infiltrate on chest radiograph, and no evidence of left-sided heart failure. And at least 2 other organ dysfunction. It includes respiratory, renal, neurological, hematological, or hepatic. So next. So these are the summary to show the progression from SIRS to septic shock. So we have SIRS, which progress into sepsis, later develop severe sepsis, and lastly, septic shock. So next. So a little overview on the pathophysiology. So the sepsis occur when the release of the pro-inflammatory mediators exceed the boundary of local environment, leading to more generalized response. So the reason for this is uncertain. However, the causes is multifactorial, as listed from the table below. So we have the effect, first due to the effect of microorganism. So the microorganism release toxin to the bloodstream that will produce many of the features of sepsis, including activation of complement, coagulation, and fibrinolytic system, which leads to microvascular thrombosis and production of vasoactive products. Second is excess of pro-inflammatory mediators, which contribute to local, excess of pro-inflammatory mediators, which may spill into the bloodstream. For example, we have TNF-alpha and interleukin-1. So it causes symptoms, for example, fever, hypotension, leukocytosis, induce other pro-inflammatory cytokine, activates the coagulation and fibrinolysis. And lastly, due to the activations of complement system, which play roles in the sepsis. So next. So the activation of the complement system, as well as the coagulation system and also mediator release or cytokine, it leads to the systemic effect of hypovolemia, cardiac and vascular failure, capillary leaks or endothelial damage, ARDS, DIC, and decreased steroid synthesis. Deal will progress to shock, multi-organ dysfunction syndrome, and lastly, it causes death. So next. So the risk factor, so the following has been associated with the increased risk for septic shock. So we have age younger than 1 month, or also called neonates, serious injury, for example, major trauma or burns, chronic debilitating medical condition, for example, uncorrected congenital heart disease, short gut syndrome, and then we have host immunosuppression, for example, malignancy, HIV infection, severe malnutrition, and then last surgical incision, indwelling vascular catheter, or other invasive device, for example, ET tube, Foley catheter, or chest tube. And then we have urinary tract abnormalities with frequent infection. So next. So sepsis can be caused by bacteria, viral, fungal, parasitic, or rickettsial infections. So bacteria and also virus are the most frequently identified pathogens. So for bacteria, among the commonest cause are Staph aureus, coagulus negative, Staphylococcus, Streptococcus pneumoniae, Pseudomonas, and also meningococcal infection. Virus causes includes influenza, adenovirus, RSV, dengue, EBV, CMV, and also lastly COVID-19. And others infection includes fungi, as I mentioned, parasitic, and also rickettsia. So next. So with regards to clinical features, it depends on the suspected site of infection. So based on the table, we need to find the source of infection. So a lot of possible infection source. So first we have upper respiratory tract, So the signs and symptoms include pharyngeal inflammation plus exudate plus minor swelling and lymphadenopathy. We have lower respiratory tract, which evidenced by productive cough, pleurotic chest pain, consolidative auscultatory finding. And then UTI, patient may present with urgency, dysuria, long or back pain, vascular catheter, for example, arterial or central venous. So symptoms include redness on or drainage at incision site, indwelling pleural catheter, symptoms redness or drainage at incision site, and then wounds or burn. Patient may present with inflammation, edema, erythema, discharge or pus. Skin or soft tissue includes erythema, edema, and lymphangitis. Next. So continue with central nervous system. It includes sign of meningeal irritation. GI infection includes abdominal pain, distension, diarrhea, and vomiting. Intra-abdomen symptom, specific abdominal symptom or sign. Peritoneal dialysis catheter includes cloudy peritoneal dialysis fluid or abdominal pain. Genital tract infection includes so divided into women and men. So women may come with low abdominal pain, vaginal discharge. Men may come with dysuria, frequency, urgency, incontinence, cloudy urine, and prostatic tenderness. Bone symptom and sign may include pain, warmth, swelling, or decreased use of the affected bone, as well as the joint, which may come with pain, warmth, swelling, and decreased range of motion. So next. So the clinical features on septic shock. So it depends whether the patient has warm or cold shock. So warm shock is distributive type of shock, which is characterized by hyperdynamic or high output physiology with decreased systemic vascular resistance and elevated cardiac output. So it suggests an early stage of septic shock. And cold shock reflect increased systemic vascular resistance and a decreased cardiac output. So it is a hypodynamic stage or late stage. So the table on your right side show the difference between warm and also cold shock in terms of the peripheries, capillary refill time, pulse, heart rate, blood pressure, and pulse pressure. So next, we move into investigation. Next, so I'll divide it into several investigations. First is bedside test. We can do a rapid blood glucose, so to rule out hypo or hyperglycemia. So for example, hypoglycemia may accompany the metabolic demand and decreased oral intake associated with sepsis in children. Okay, next is arterial or venous blood gas to rule out metabolic acidosis. So elevations of, and then blood investigation includes FBC to rule out an acute infection, evidenced by, for example, leukocytosis and its differential. And then serum lactate to rule out lactic acidosis. So elevated lactate of more than 2 may suggest tissue hypoperfusion, and it is also predictive, in which if the initial blood lactate is more than 3.5 in pediatric patient, it may, with septic shock, it may associated with increased risk of mortality. And then serum electrolyte to rule out electrolyte imbalance, for example, hyponatremia, hypokalemia, which may accompany disease process associated with sepsis and septic shock. And then we have blood urea nitrogen and serum creatinine. Increase in blood urea nitrogen may suggest dehydration, and to rule out also renal dysfunction, evidenced by serum creatinine increase. So next, serum. Okay, next is serum calcium to rule out hypocalcemia, which can affect the myocardial function and also vascular tone, and should be corrected if present. And then we have LFT to rule out liver dysfunction, evident by increase in bilirubin as well as liver enzyme. And then to rule out the IVC, we may request for coagulation profile and also low fibrinogen and D-dimer. And then blood culture to rule out bacteremia. And then to rule out urinary tract infection, we may request for urinalysis and urine culture. So next. So imaging, we may request for a chest radiograph to rule out pneumonia, pulmonary edema, and cardiac failure. CT scan of the brain to rule out intracranial hemorrhage. CT abdomen as well as ultrasound may rule out abdominal abscess. So next, so the management I took it mostly from PITS protocol. So it divides into initial, further, and supportive therapy. So for initial management of sepsis and septic shock, so the first hour is very important. So first, recognition of sepsis and septic shock. After that, apply oxygen and continuous cardiorespiratory monitoring. So and next, intravenous or intraosseous for blood investigation, for example, as I have mentioned earlier, as well as IV line for treatment, which includes fluid resuscitation and antibiotics. So fluid resus, we may give 20 ml per kilo of crystallite, for example, 0.9 saline bolus. So the maximum is 40 ml per kilo. And then antibiotic, so initial antibiotic open connection within 1 hour. So the small box on your right is the empirical antibiotic, different in based on the age of the patient. So less than 3 months, we may offer cefotaxime or penicillin, and if more than 3 months, we may offer ceftriaxone or cefotaxime. And then we may also consider to give inotropes and vasopressor to increase the BP. So it is considered if persistent shock after maximum 40 ml per kilo of fluid has been given. So we may give adrenaline and noradrenaline. And then the child also may be managed in ICU. So next. So with regard to inotrope and vasopressor, so we may give it through peripheral lines or central line, but preferably we infuse via central line and avoid concurrent use with other IV or medication, IV fluids or medication, and have an invasive BP monitoring. So for peripheral line, so the solution, the drug should be diluted. The other alternative, we have dopamine and dobutamine. So dopamine only give in patient with low risk of tachyarrhythmia or absolute or relatively bradycardia, or if noradrenaline is not available. So dobutamine is given in patient with persistent hyperperfusion despite adequate intravascular volume. And then also can consider vasopressin if patient is in the refractory to noradrenaline or adrenaline. Next. So for respiratory support, it depends on the conscious level of patient. If the patient is normal, so we may offer non-invasive ventilation such as high flow nasal cannula, CPAP or BiPAP. If abnormal, consider intubation. Cautious during intubation, we need to consider using ketamine for sedation, as sedative drug may result in crash of BP. And then start inotrope support prior to intubation. And then keep the SpO2 of 92 to 94% and PaO2 of more than 80 millimeter mercury. Next. So next, further management. So lactate level. So lactate level, as I mentioned earlier, is important to monitor the tissue hypoperfusion. So if patient have elevated lactate of more than 4 millimole per deciliter, so we may need to do frequent sampling to guide for resuscitation. And then consider second line inotrope or vasopressor, for example, vasopressin to improve BP, maintain the blood glucose of about 4 to 8 millimole per liter, and then titrations of the fluid and inotropes to optimize the vital sign, urine output, and conscious level. So echocardiography may help to determine the fluid status and the cardiac functions of the patient. Next. So next is on the goal of resuscitation in the pediatric septic shock. So based on the pediatric protocol, it divides it into system. So first we have cardiovascular. So what we want in the therapeutic endpoint is the heart rate normalized for all age, for the age of the patient, and the capillary fill time less than 2 seconds, normal pulse quantity, no different in central and peripheral pulse, warm extremity and blood pressure normal for age. For neurology, the therapeutic endpoint is the normal mental status. For respiratory, improve of work of breathing and respiratory rate. And lastly, for renal, expect urine of more than 1 ml per kilo per hour. Next. So the supportive therapy, steroid can be used in refractory shock with suspected or definite adrenal insufficiency. So the refractory shock based on up-to-date, there are 2 types, which is fluid refractory septic shock, which exists when the cardiovascular dysfunction persists despite at least 60 ml per kilo of fluid resus. And the second one is catecholamine resistant septic shock, exists when the shock persists despite therapy with dopamine of more than 10 microgram per kg per minute. And then we have intravenous immunoglobulins can be used in toxic shock syndrome, and then VTE prophylaxis in high risk group patient, and then PEG Rexel in the symptomatic anemia patient, and then continuous renal replacement therapy CRRT in the hemodynamically unstable patient with acute kidney injury with indications of dialysis, and then stress ulcer prophylaxis in the high risk of GI bleeding. For example, we may use PPI or H2 receptor antagonist, and then enteral nutrition for patients without feeding intolerance. And lastly, a family conference to update the patient condition and progress and set goal of care. So that is all for me. Any question?
Okay, any questions? Any questions? So basic sepsis is a syndrome, right? Sepsis is a syndrome. So it's not a diagnosis. So you don't have a diagnostic criteria. For example, like you buat this investigation positive, then you diagnose sepsis. No, it's a syndrome. As long as the child got the compilation of symptoms, then you can diagnose sepsis. Okay, and you need to have a low threshold of treating sepsis. Okay, don't wait until full-blown sepsis, until shock for you to treat. Okay, dia more to expected management. Okay, ada soalan?
Doktor, saya ada soalan regarding the mid-parental height just now. Bolehkah kita guna mid-parental height punya calculation tu untuk kira the height potential untuk child yang below 18 years old? Sebab ada baca kata dia hanya digunakan untuk child yang more than 18 years old.
Maksudnya child for more than 18 years old?
Maksudnya kita kira mid yang formula tu digunakan untuk patient yang 18 years old and above.
Kita tak nak do. No, that is totally not right. Why do you calculate? Why do we calculate mid-parental height?
Untuk kira the expected height potential.
Kita nak predict height kan? End height kan? Final height. Kita nak predict final height. So kalau you rasa 18 tahun, dia akan meninggi lagi ke?
Tak.
Tak kan? Of course, 18 years old, dia dah reach final height dah kot. So height potential ni, you measured for those yang more than 5 years old. Once you dah label the short stature, you nak diagnose kan ni, you want to diagnose short or tall stature. Then you need to calculate the mid-parental height dengan height potential. Then you look at the current height. Is it within the height potential ataupun tak? Faham tak? This is very difficult untuk just to explain verbally. You need to see, we need to meet so that I can show you how to apply that. Because I need a growth chart, I need to plot the growth chart. I boleh guna whiteboard lah, tapi I'm using handphone now, so it's a bit difficult. Okay, faham? So that's totally not true. That's totally not true. So you calculate the height potential for those yang more than 5 years old. Tapi untuk baby, for example, baby 2 years old, you know with nutrition you can intervene. Nutrition can actually affect the final height kan? So would you calculate the height potential untuk baby? No, you won't, because it won't be accurate. For example kan, now you rasa dia punya height potential dekat 50 centile, mid-parental height as 50 centile. You've got a baby, you calculate the mid-parental height as 50 centile. And then you bagi makan baby tu, dia boleh reach more than that. Dia akan reach more than that. Faham tak? Sebab dia tak label as short stature lagi, dia just stunted. Which means with nutrition dia can gain height. Faham tak?
Faham? Thank you, Doktor.
Okay. Buku mana you baca tu? Buang je aku tu. Okay. Lagi?
Saya ada soalan. Pasal short tadi saya kurang jelas. how do we determine nak pakai dopamine ke dobutamin ke?
Okay, frankly speaking lah, no one knows. Okay, no one knows. There's no evidence saying you kena guna ni, you kena ni. Every center, every ICU got different guideline. Every doctors have their own preference. Doesn't matter. Okay, what you need to know is when you need to start inotropes. Okay, cuma you have to have common sense lah. Okay, kalau this child dia ada cold shock. Cold shock means dia tak ada vasodilatation kan? The reason a patient got warm shock is because dia ada reduced systemic vascular resistance. Kan, dia ada distributive shock. So what happen is all the vessels, because of the toxic and also infection mediators, cause dilatation of the blood vessel kan. Systemic dilatation of the blood vessels causing all the dilatation of the peripheral blood vessels that leads to warm. So the child become warm because of dilatation. Faham? Redistribution of blood to the periphery, causing warm shock. So what is the best inotropes? Kalau in this case, what is the best inotropes? Anyone?
Noradrenaline.
No add lah, kenapa?
Because it acts directly to the heart.
Ada pula. Because they works dekat periphery. No add, they works dekat vessel tau, dekat blood vessel, dekat you punya artery. Dekat muscle. You punya smooth muscle dekat vessel. So they constrict the smooth muscle, so they redistribute the blood back to the heart. Faham tak? So in warm shock, the best of course no add. Tapi in a child with cold shock, which means dia dah go beyond that. Maksud dia dah vasodilatation and now dia dah cold. Vasodilatation, dia shock. So body compensate, try to push the blood back to the heart. So you don't have vascular resistance, you don't have reduced vascular resistance ataupun vasodilatation of the peripheral. So in this kind of case, you boleh guna apa-apa pun. You boleh guna dopa, dobu, all things that work centrally. But no add is not suitable lah in this case. Kalau cold shock, faham? Cold shock is not suitable untuk you use no add lah. Because no add work peripherally. Dia tak work centrally. So you need to use adrenaline, dobu, dopa, that works at the heart level. Receptor in the heart. Okay, faham? Faham tak? So I think at your level, doesn't matter. You don't have to know what inotropes need to be used. Maybe in ICU setting, you need to know lah. But pediatric punya posting, you don't need to know. However, you need to understand how the mechanism of action of each inotropes. Okay. Next, soalan.
Doktor, tadi saya tak dapat tangkap reason why we do bone age in short stature. Kita nak know the causes ke, nak for treatment later on ke, macam mana?
So what hormone affect your bone age? Sorry. What hormone yang affect you punya bone age?
Growth hormone.
Growth hormone lagi. Sex hormone.
Hormone.
Kan? Okay, if you got a child kan yang short. Okay, you short. Kalau dia short and then you tengok bone age dia sama macam umur dia. Faham tak? Development of bone age dia sama macam umur dia. Contoh, you got a child 9-year-old yang short. Bone age dia 9 juga. Okay. So you rasa kat mana problem dia? Is this a true short ataupun this is a false short? Maksud pseudo short. This is a true short lah. Memang dia pendek kan? Bone dia 9 tahun tapi dia memang pendek. Tapi kalau you've got a child 9 years old who is short and then bone age dia baru 6 tahun. Is it a true short stature ataupun this is actually a pseudo short stature? Pseudo lah kan, sebab sebenarnya dia umur dia memang dia pendek sebab umur dia 7 tahun. Walaupun chronological age 9 years, tapi actually umur dia sebenarnya 6 tahun je, sebab tulang dia memang 6 tahun. Which one can lie? Umur you ke ataupun bone you? Jodoh tak
nak.
boleh lie lah. Kalau you dah lahir tahun 87, then you macam I lah 33. Takkannya 34 takkan you jadi 30 tahun. Kan?
Okay.
Tapi kalau bone tu dia represent you punya hormone lah. So you tahu. Kalau dia ni pendek, and then bone age dia memang delay, then you know memang dia pendek sebab bone dia immature. Faham tak?
Okay,
Faham kan?
so jadi in that case kita boleh bagi growth hormone lah kan nak treat this patient.
Not necessarily. So you kena investigate lah kenapa. Of course lah, maksud dia kita boleh bagi growth hormone. You are right lah to say. Maksud dia kalau kita bagi growth hormone dia boleh meninggi sebab kita ada potential lagi. Faham tak? Tapi kalau contoh budak yang 7 tahun tapi bone age dia memang 7 tahun tapi dia pendek macam 5 tahun, kita tak boleh buat apa dah.
Oh. Okay.
You boleh bagi growth hormone tapi potential dia tak banyak lah. Faham tak? Faham kan?
Okay. Thank you, Doktor.
Okay, welcome. Ada lagi soalan? Mana ni? Okay, soalan lagi? Okey lah, hari nak pergi sembang Jumaat lah. Okay kan? Any soalan you boleh WhatsApp je lah. Okay. Okay,
Okay, Doktor.
Thank you very much, Doktor.
Thank you, Doktor.
Thank you, Doktor.
Okay, Doktor.